Okay, so let's talk about the musculoskeletal system. We're going to talk about the function of the musculoskeletal system, some tests that we do to diagnose certain conditions of the musculoskeletal system, and then we'll go on and talk about some conditions. Okay. So, by the way, this is Dr. K, Dr. Kiragesian, or Dr. Greg, giving this voiceover, and we'll try and make sense of the chapters in the ATI. I'll focus on some topics more than others, okay? And I'll mention what is commonly done in real practice and when you're working compared to, no, this isn't that common, okay? So let's go on from here. Okay, so this slide is really just a reminder from pathophysiology about the function of the musculoskeletal system. So definitely one of the main functions is to support the body, right? So we have ligaments attaching to the bones that hold them all together. We have tendons attaching them that allow muscles to move. It's a huge reservoir of minerals, right? Calcium, phosphate. So the vast majority of our calcium is stored within the bone. Protection of vital organs. So we have a rib cage that protects our heart, protects the lungs. We have a vertebral column that protects the spinal cord. The skull protects the brain, and so on. Okay, so very important for protection of vital organs. That's not to say that every vital organ is protected. We do have some weak spots in our system. So, for example, the liver is tucked under the right ribs, the right lower ribs. The spleen is tucked under the left lower ribs. They're still prone to injury, but the ribs do provide some protection. Our abdomen is quite open in terms of very little protection to injuries directly to the abdomen. Okay, so there are some potential weak spots, but in general, the vital organs do have some protection from bones. Allow movement, right? So that's where through muscle contraction, voluntary movement occurs. Maintaining body temperature is through the blood supply that's circulating through the skin that can vasoconstrict to limit the release of heat, or vasodilate to allow for sweat and release of heat. Okay, so our body wants to maintain a very tight control of the body temperature. Okay. Promotes return of venous blood to the heart. Well, that would really be through movement, right? So when we're walking, for example, the contractions of muscles in our legs, in our calf, in our thighs, the muscles are continually contracting, and they're compressing those veins, which then allow the blood to move forward back to the heart. Okay. Reservoir of blood cells. So we have a huge reservoir of blood cells within our bone marrow, right? In fact, our circulating cells in the blood are made in the bone marrow. So your red blood cells, your white blood cells, your platelets are all made within the bone marrow. Okay, and I mentioned the reservoir for essential minerals such as calcium and phosphate. Okay, and we'll get into that a bit more. Okay, bone maintenance. So, by now you will have heard that calcium in our diet, vitamin D in our diet, or through synthesis in the skin, um, maintains healthy bone. Okay, so we need a proper amount of calcium in our diet and a proper amount of vitamin D, which really takes about 20 to 30 minutes of sunshine, but we often get some vitamin D in our diet as well. Okay, thyroid hormone. So normal thyroid function or normal thyroid hormone levels maintains the bone. But I want you to remember that excessive thyroid hormone can lead to osteoporosis. Okay, so if someone, say, has Graves' disease and they have excessive thyroid hormone, or they're taking thyroid hormone because they had hypothyroidism, but they're taking too much, over the span of years, this thins the bones and leads to osteoporosis. Okay, cortisol. So if you have normal cortisol levels, no problem. But if you have excessive cortisol levels, whether it's from a condition such as Cushing's syndrome, where your adrenal glands make too much cortisol, or you're on exogenous cortisol, such as prednisone or dexamethasone, that tends to thin the bones. So excessive cortisol leads to osteoporosis. Okay, and that's a big issue if someone's having to take prednisone for long periods of time, say for severe asthma or severe Crohn's disease or ulcerative colitis, and they're on low dose cortisol or prednisone, it leads to osteoporosis. Okay, what else? Estrogen. Well, estrogen protects the bones. It maintains the bones, right? So not only does it enhance formation of bones, but it also inhibits bone resorption or bone breakdown. Okay, so premenopausal women have some protection from osteoporosis because they have high levels of circulating estrogen. Testosterone, again, it also stimulates bone and skeletal muscle growth. And so men don't tend to be as prone to osteoporosis as women because men tend to maintain testosterone levels through life. They can gradually drop as men get older, but not to the same extent as women and estrogen. So women at around the age of 50, plus or minus 2 years, so around menopause, they have lack of production of estrogen because the ovaries stop functioning. They stop producing estrogen. And in that 5 years after menopause, women can lose tremendous amounts of bone mass. Okay, and we'll talk about that a bit more. Okay, so remember, postmenopausal women, because of the lack of estrogen, are at significant risk of osteoporosis. If a woman has her ovaries removed for some disease, say they have severe endometriosis and it's covering the ovaries, and the ovaries need to be removed, well, they're at risk for osteoporosis because they no longer have circulating estrogen. And that's why younger women, say in their 30s or 40s, that have a procedure where either their ovaries have stopped functioning or they've been removed, need to go on to estrogen replacement. Otherwise, they'll have rapid loss of bone. Okay, so let's move on to some diagnostic procedures when we're talking about the musculoskeletal system. And there's a number of tests that we can do depending on what condition we're looking for. So if it's a fracture, okay, no problem. We'll do an x-ray. If we suspect somebody has weak muscles due to a muscle disease, we'll do a different test. So it just depends on what symptoms the patient presents with. That will determine what tests we'll perform. Okay, and we'll get into that now. Okay, so let's go through these, and then we'll go into them in a bit more detail. So x-rays, what are they good for? Well, they're good for looking at potential fractures. So somebody goes over on their ankle and we want to see if they have an ankle fracture. X-rays are fantastic for looking at potential sites of fracture. A CAT scan, again, say somebody has a fracture but it's very hard to see the three-dimensional part of the fracture. Say an elbow fracture, where there might be multiple areas of the fracture. We can do a CAT scan to look at that fracture and get even more in-depth detail about the fracture. Okay, so it just depends on whether we're happy with the x-ray and it's basically a simple fracture, and it's just a matter of going on and treating the fracture. MRI. So MRIs are fantastic for looking at joints. Okay, so somebody has a hip injury or a knee injury or ankle or shoulder, and we really want to look inside the joint, but not having to put a camera into the joint, just with an imaging test. MRI is the best. Okay, so it looks at the ligaments, it looks at the cartilage within the joint, it can see the tendons around the joint, it can see if something's torn within the joint. So MRIs are fantastic for looking at joints. The other part of the musculoskeletal system they're very good at looking at is the spinal canal. So if we think somebody has, say, a compressed disc, so an intervertebral disc that's compressing the spinal cord or compressing the nerves of the spinal canal, MRI is by far the best test to do to look at that. Okay. If we suspect somebody has, say, a C-spine injury, and we do an x-ray, we don't see any fracture, but we still think they have some kind of injury to the spinal cord, not the bones, of the neck, we could do an MRI, which shows us the spinal cord, it shows us the nerves leaving the spinal cord. So very, very sensitive test, okay? And remember, there's no radiation associated with an MRI. There's minor radiation associated with an x-ray, and there's significant x-ray, depending on what body part is being imaged, with a CAT scan, okay? What's an arthroscopy? Well, that is where we're going to put a camera into a joint, okay? And we're going to have a look in at the joint directly on the camera, and we can also do procedures while we're looking with the camera. So an example would be looking into a knee joint, seeing that there's a meniscus that's torn, and then through another port that's punctured into the knee, we can cut off the loose meniscus, or it can be tacked down. Okay, so that's arthroscopy. Nuclear scans we'll talk about. Another term for them is bone scans, and basically this is an injectable substance that will go to the bones, and then we can perform imaging tests to look at the entire all of the bones to see if there's any disease within the bones. So sometimes we'll do bone scans, say, for cancer. Or if we think there's a fracture, but we can't see it on x-ray, sometimes we'll do a bone scan, and the bone scan will light up the fractured area. Okay, we'll get back to that. So a DEXA scan, so a dual energy x-ray, DEXA is good enough, okay? So that's a bone density scan. So we call those bone density scans. What are they for? Osteoporosis. Okay, so a DEXA scan or a bone density scan. We don't usually get into that long word there, dual energy x-ray, absorptiometry, or okay. Electromyography and nerve conduction studies. Now we're looking at the muscles and the nerves that go to the muscles. So electromyography is basically putting an electrode into a muscle to see what's happening within the muscle. And nerve conduction studies is to see if the nerve that's left the spinal cord, say, is arriving properly with an impulse to the muscles. Okay, and we'll get into some of those as well. Okay, so here's an arthroscopy. Looks like it's being done on a, that could be a shoulder or a knee. Hard to tell from this image. But they both, there's arthroscopies done on either of those joints. So arthroscopies are super common, especially of the knee joint. Okay, so one of those puncture sites will have a camera that they're able to visualize on a screen, and another will have an instrument where they're able to remove loose parts within the joint, such as torn and damaged ligaments or torn meniscus, if we're talking about the knee joint. Okay, so it gives a direct view of someone who comes in with, say, joint swelling, ongoing pain. Crepitus is that kind of crunching sound when you move a joint. Or if someone has joint instability and they just can't walk on the joint anymore. Say it's the ankle or the knee and it's just unstable. They can't mobilize. Well, an arthroscopy can be can be used to look inside the joint. I'm going to tell you, MRIs are used much more for this because they give the same amount of information. The only difference is with an arthroscopy, you can actually do something while you're inside the joint. Okay, but MRIs are non-invasive, so there's an advantage to them. Okay, so you can see the indications there: repairing torn ligaments or meniscus, doing biopsies within the joint, and looking inside to see why someone has recurrent joint swelling or pain. Okay. What's the contraindication? Well, definitely if you have any kind of a skin infection on top of the joint, well, no one's going to puncture into a joint and go through a skin infection such as cellulitis. That definitely would need to be treated first. Otherwise, you could introduce bacteria into the joint, which is always serious. Okay, so whenever you get bacteria within a joint, which is called septic arthritis, that is a very serious condition because there should never be any bacteria within the joint. It's a completely sterile environment. Okay. Okay, so pre-procedure. So usually this is patient education about the procedure, what they're about to undergo. They may receive some sedatives and some analgesics if required for the procedure. Now, post-procedure, again, they might need analgesia after arthroscopy's been done. Typically, they're advised of protecting the joint and then RICE, right? So rest, ice, compression, elevation. Okay. Usually, it's for about 24 hours. Okay, after the procedure. Okay. So the big complication for this procedure is you need to report if you get a fever, if your joint looks red, if your joint becomes more tender, if it becomes more swollen and red, because of that risk of an infection in the joint. Okay, it's definitely a low risk with this procedure because they're really sterilizing the skin and making sure that there's no surface bacteria, but it's always possible. So the patient's going to receive a lot of advice on you need to report to us if there's any increased joint swelling, increased pain, fevers, or redness. Now, whenever a procedure is done on a limb, it's always a good idea to check the neurovascular status beyond where the procedure was done. So, for example, if this was an arm, well, we would check the color of the hand. We would check the pulses of the hand. We would check the sensation of the hand, okay, and the motor function of the muscles of the hand. So we want to see that the blood supply is going properly to the hand and the nerve supply is going properly all the way to the hand, okay, to make sure that nothing was injured during the procedure. Okay, let's move on here. Okay, so let's talk about a bone scan. So a bone scan is what I mentioned before. We're looking for something, for an abnormality within the bony system of the patient. Okay, so whether it's a fracture that we just can't see on x-rays, but we still suspect it, or we want to see if there's any metastatic cancer to the bones. A bone scan will light up, as you can see in the image here, if there's anything abnormal within the bone. Okay, so what happens is the patient will go to a hospital. They'll be injected with a radioactive isotope, and then they'll go away for 2 to 3 hours, and they'll return, and they'll receive this imaging test that basically will look at all the bones. Okay. Now, if it happens to be that we're just looking for a wrist fracture that we can't seem to find on X-ray, then they'll do a bone scan of the wrist. Okay, they won't do the whole skeletal system. Okay, but you can see in this image, they're basically getting the entire skeletal system. And often a patient that has cancer and we're looking for metastatic spread to the bones, they'll get a full bone scan of the entire skeletal system. Okay, so what does the patient receive in terms of advice pre-procedure? Well, they're going to be informed about the procedure for sure, and then they're going to be asked about allergies. Do they have any allergies to previous dyes or injections for imaging tests? Okay. Definitely they're going to be asked about pregnancy and lactation and renal disease, because that's where the radioisotope is going to be excreted. So someone with significant kidney disease, that would be one of the reasons to reconsider whether a bone scan or a nuclear scan should be done. Okay. Now, typically the bladder is emptied prior to the procedure, so that all those pelvic bones that you're seeing in that image there are visualized properly. Okay. Post-procedure, well, the advice is to drink lots of fluids to excrete this radioisotope out through the urine, right? Now let's look at, we're gonna move on, but let's look at the indications here. So bone pain that we really don't know what's going on. Say we do an X-ray and we can't see much, and the person has persistent bone pain. Well, the bone scan can light up an area if there's really something within the bone. Okay. So let's look at the indications here. Arthritis. Well, arthritis is usually pretty well picked up by an X-ray. So often we wouldn't necessarily go for a bone scan with run-of-the-mill osteoarthritis. We can see that on X-ray. Okay. Osteomyelitis. So that doesn't always show up on X-ray early on. Now, as the infection with osteomyelitis progresses and the bacteria are chewing away more of the bone, then it starts to show up on X-ray. But that's a bit later on. Initially, when someone comes in with bone pain and it happens to be osteomyelitis, it doesn't always show up initially on X-ray. Okay. So a bone scan can pick up bone pain and we just don't know the cause, and it ends up being osteomyelitis. How about a fracture that we don't see anything on X-ray? Sometimes wrist fractures can do this, where we just can't see the fracture, and then we can move on and either do an MRI or we can do a bone scan. Osteoporosis, we're going to talk about another test coming up that's much more useful for osteoporosis to diagnose it, okay, which is going to be the DEXA scan. So we'll talk about that in a minute. Bone cancer. Absolutely. We do bone scans all the time for patients that we want to clear the bones of any cancer, or if they're complaining of bony areas and we're concerned that there's cancer in the bones, we'll do a bone scan. Okay. So there's the pre-procedural contraindications. So allergies to the radioisotope, pregnancy, significant renal disease. Okay. Post-procedure, just drinking lots of fluid, right? Remember, pre-procedure, empty the bladder so we can see the pelvic bones. Okay. What's a complication of this? Well, the kidney can take a bit of an injury, so an intrinsic renal injury because of the radioisotope that's been injected. Okay. Most of the time, the kidneys recover from this injury, and it's usually in patients that already have an injury to their kidneys, so they have renal disease, or they're dehydrated. So they've come in dehydrated, they didn't drink a lot of fluids, and the flow to the kidneys is reduced, so the isotope is more concentrated. But in general, most people tolerate this test just fine. Okay, the next test, a DEXA scan or a bone density test. This is really just for osteoporosis. Okay, so who is going to be getting DEXA scans? Well, it's going to be women more than men, for sure. And typically, it's you can have a baseline DEXA scan, to see someone's bone mass even before they're menopausal, say in their 40s, or we can screen for osteoporosis, typically after the age of 50. Okay, so patients typically go from this phase of normal bone density to what's called osteopenia, to then osteoporosis. So it's basically the degree of bone thinning, right? So this particular test, there's no injection, there's no radioisotope, there's just two beams that are used, typically at the hip, sometimes at the vertebral column, the vertebra. And what they do with these is they put it through a computer, and it tells us the density of the bone. Okay, and then you're given a score. Okay, and the score tells us whether you have normal bone density, osteopenia, meaning it's getting a bit thin, but it hasn't reached the osteoporosis stage, or yes, your bone is thin enough to be considered osteoporotic. Okay. So how do patients with osteoporosis typically present? Well, recurrent fractures. So they could have wrist fractures, vertebral fractures, hip fractures, basically fractures in any of those areas, or others. Okay, but wrist, vertebral, and hip are very common places to fracture with osteoporosis, and sometimes with a relatively minor injury. Okay, so they present with fractures, they present with loss of height because the vertebra of the spinal column are getting compressed slowly, so they're losing height, or they can present with bone pain, right, from injuries. Okay, so osteoporosis in itself doesn't give bone pain, but minor fractures can lead to bone pain. Okay, so typically this is not recommended if you're pregnant, just because there is a bit of X-ray associated with this, but there's no injection. Okay, so really think of this test for detecting the level of bone density to diagnose either osteopenia or osteoporosis. Okay, so what's electromyography? Well, that's just putting a needle into the muscles of concern and to see what happens within the muscle with a contraction. Okay, so it's really just studying the muscles, which makes sense, electromyography. What's a nerve conduction study? Well, this also involves attaching electrodes to the skin, and they detect the impulse, the nerve impulse, from one area of the nerve to another area of the nerve to see if there is normal conduction of the nerve impulse down the nerve. So a perfect example of utilizing a nerve conduction study is carpal tunnel syndrome. Okay, so we'll talk about this a bit more later, but it's where a nerve gets compressed at the wrist, so in the carpal tunnel of the wrist, and you get specific symptoms. So you typically get numbness of your thumb, your first digit or your first finger, your middle digit, and half of the fourth digit. Okay, so you get numbness there, and you get weakness of the hand. So you have difficulty holding things. People come in and say, you know what? Not only do I have numbness of my thumb and 2.5 digits, but I have problems holding cups now. I'm dropping things. And it's because the nerve that's being blocked is called the median nerve in the wrist, and it's creating weakness to the muscles of the hands. Okay, so really we're trying to diagnose a impingement of the nerve in the carpal tunnel with a nerve conduction test. Okay, so what are other indications? Well, basically any neurological disease, say of a peripheral nerve, or a muscle disease, well, that's where we would use electromyography, or a neuromuscular disease, so myasthenia gravis, or other diseases where we just want to see if the nerve impulse down the nerve is getting to the muscle normally and causing a contraction. Okay? So that's electromyography, that's for the muscle. Nerve conduction test, that is for looking at the conduction of the nerve impulse to the muscles. Okay. Okay, so in terms of pre-procedural checks, sure, asking the patient if they're on anticoagulants. We try hard not to poke people with needles if they're on anticoagulants. Muscle relaxants, because it's going to affect the contraction of the muscles. So if we're looking at doing electromyography, well, if you're on a muscle relaxant, it's not going to be as reliable. Okay. Skin infections, because we don't put needles through infected skin. Okay, so there's the reasons there. The last one, in terms of not putting creams or lotions on the day of the test, well, those areas are just going to be completely cleaned off before the electrodes go in. So, you know, to lubricate your skin or to put some kind of oil on your skin wouldn't be a good idea. Okay. Post-procedure, sometimes there is bruising at the site, right? Because it's punctured a little blood vessel and caused some bleeding under the skin. Reporting any areas that have become red, swollen, tender, because there's always a risk of developing an infection, right? So, and then the application of ice to prevent a collection of blood called a hematoma. So typically at the insertion sites, you can put ice packs on them just temporarily. Okay, so basically done this first chapter. So I'm just going to remind you, with CAT scans, yes, there's radiation. Sometimes we use injectable dyes with CAT scans. So that's going to require checking whether they have allergies to dyes. Kidney function test is required to see that they have normal BUN and creatinine. Okay. When it comes to an MRI, definitely we go and check that there's no metal. Patients usually have to fill out a questionnaire in terms of, do you have any metallic objects in your body? Have you ever had any surgeries? Have you ever had an eye injury? And sometimes, actually, before an MRI, we'll do an X-ray of someone's skull. If there's any potential that they may have had a bit of metal in their eye from a previous injury, we'll just X-ray the skull, and looking to make sure that there's no little bit of metal anywhere, because MRI is a very powerful magnet, And any metallic objects in the body, it won't necessarily pull out the metal. And, you know, in this really graphic um, scenario of where metal's being suddenly pulled out and ripping through the body, but small bits of metal can heat up within the body. And we want to know if someone has metal in their body that can heat up, okay? Especially if that little piece of metal is in the eye, because that can cause heating of the area and then injury to the eyeball, okay? So basically any type of metal, including, do you have a pacemaker?